Okay, so we are live now. Once you join the chat, you can leave your name in order to have an interactive session. Okay, so we are going to start in 2 minutes. If you join the chat, please let me know your name. This way we can have an interactive course. Okay, so we will start the course. Today we are going to discuss about autoimmune diseases and electrolyte disequilibrium. The first patient is a 30-year-old patient who was treated with carbamazepine for bipolar disorder. He came to the ED obtunded. On the electrolyte panel, the sodium turns out to be 121 milliequivalents per liter. His serum osmolality is 275, while his urine osmolality is 120. What is the most likely cause of his hyponatremia? Potomania, hypothyroidism, CADH, or renal failure? Let me know your answer in the chat box. Okay, so the answer is C. Carbamazepine causes CADH as a side effect. However, the other choice, namely hypothyroidism, would have been a correct assumption if the patient was on lithium. Also, lithium can cause diabetes insipidus. Let's see another clinical vignette regarding hyponatremia. A 65-year-old patient comes to the ED with hypovolemic, hypotonic hyponatremia. His sodium excretion fraction is 3%. What is the most likely cause of hyponatremia in this patient? CKD, nephrotic syndrome, congestive heart failure, or cirrhosis? So the answer is A, chronic kidney disease. Let's talk about hypotonic hyponatremia. How do we interpret it? So if the extracellular fluid volume is low, we have hypovolemic hypotonic, and then we discuss, based on the fractional excretion of sodium, about GI losses, skin losses, and third spacing if there's less than 1% fractional excretion of the sodium. If the fractional excretion of the sodium is greater than 2%, then we can discuss about diuretics, urinary obstruction, adrenal insufficiency, or bicarbonaturia. If the extracellular fluid volume is normal, we measure the urine osmolality. High urine osmolality means CADH, hypothyroidism, or glucocorticoid deficiency, while low urine osmolality means primary polydipsia and beer drinkers' potomania. An elevated extracellular fluid is indicative of hypervolemic hypotonic hyponatremia with either fractional excretion of sodium that is less than 1%, cirrhosis, congestive heart failure, or nephrotic syndrome, or, as we had with the anterior patient, if the fractional excretion is greater than 2%, then we have acute kidney injury or CKD. Are there any questions on this topic? Okay, now we have a 32-year-old patient that comes to the primary care physician complaining of 3 months of paresthesias at the palm level. Previously, he suffered a wrist laceration while chopping logs. On the physical exam, the patient has a cold right hand with wrist edema. His nails are much longer on the right hand than on the left hand. What is the most likely diagnosis? Carpal tunnel syndrome, cubital tunnel syndrome, complex regional pain syndrome, or ganglion cyst? Please let me know your answer in the chat box. So the answer is C. The complex regional pain syndrome presents as hyperhidrosis or hypohidrosis and especially hypothermia. It can also present with edema, with hair and nail growth, and usually the pain does not have an anatomical distribution. In regards to the treatment, initially the patients are given NSAIDs with physical and occupational therapies. If this fails, other drugs are used such as corticosteroids, low-dose TCAs, gabapentin, pregabalin or calcitonin. As a last resort measure, we can use sympathetic blockade. Is there any question on this topic? Okay. Then, as a break, you can support the growth of the channel by becoming a patron, link in the description. Also, if you want to see more USMLE related content, you can access the link in the description. For our second part, we will talk about autoimmune diseases. A 50-year-old female presents with difficulties in climbing up the stairs. There is a violaceous rash around her eyes. On her hands, there is scaling over bony prominences. The physician orders a chest X-ray and a spirometry. On the chest X-ray, there are peripheral reticular opacities. The spirometry shows a restrictive pattern with reduced DLCO. Which antibodies are most likely seen in this patient causing the respiratory findings? Anti-MI2, so anti-helicase, anti-Jo1, so anti-synthetase, anti-signal recognition particle, or anti-MDA5. Please let me know your answer in the chat box. The answer for this question is anti-Jo1, so anti-synthetase antibodies. Next, we have a 45-year-old female who presents to the ED with a newly onset rash that spreads from her neck to her chest. The patient complains of abdominal fullness for some time. During the physical exam, the wave sign is present. Which antibody is the most likely responsible for the newly onset rash? An anti-helicase antibody, an anti-synthetase antibody, an anti-signal recognition particle, or anti-MDA5? You can leave your answer in the chat box or in the comments. Okay, so the answer is A, anti-helicase antibodies. To make it clearer, we have antibodies that are seen in both dermatomyositis and polymyositis. The anti-helicase antibodies are frequently seen with dermatomyositis. They are responsible for the V sign or the Scholl sign. They are an indicator of a good prognosis. The anti-synthetase antibodies, on the other hand, are seen in both the dermatomyositis and polymyositis. They are associated with interstitial lung disease, with Raynaud phenomenon, with arthritis, and mechanics hands. Lastly, we have anti-signal recognition particles, antibodies. They are an indicator of poor prognosis. Patients with anti-signal recognition particle antibodies have a high disease activity with increased levels of creatine kinase. They also present with necrotizing myopathy. Okay, are there any questions regarding the antibodies? If there are no questions, then this was the course of today. Please let me know in the comments if you'd like to see a subject or a topic discussed. Until next time, take care and